Do I need to make it darker, or is it okay? Oh. I dim the lights, everyone falls asleep on me. All right. So recording, test, yes. So we're just gonna pick up kind of where we left off last week. So last week we discussed the arteries. Discussed central arteries, peripheral arteries, some of the arterial anatomy, major vessels, cerebrovascular, peripheral, central. In terms of, like the quiz and for us for ultrasound and vascular boards, just really focus on the ones that we go over in class. So I know the workbook goes in tremendous detail about all those little small branches and arteries. Like, don't worry about that. Just focus on the ones that, we go over here in lecture. So like utilize some of those diagrams and charts that I had, where we were practicing going through labeling, where I had the blanks. So, I mean, that's good practice for you. If you can, memorize and label those, then you should be okay. So just really focus on doing that. Great. So venous, central and peripheral venous anatomy, a little bit of, then we'll discuss some of the microscopic anatomy as it pertains to the veins. So in terms of central venous anatomy, we need to know the inferior vena cava and its major tributaries. So the vessels that drain into the inferior vena cava. So arterial side, our central, we have the aorta. The venous side, we have the inferior vena cava. We'll discuss some of the peripheral venous anatomy. So the actual anatomy system, veins for the upper extremities, veins for the lower extremities, and then go into some of the microscopic anatomy of the vessels. So talking about the arterial walls and the venous walls, their similarities, their differences. So central venous anatomy. So we have the inferior vena cava. So it originates, distally by the coming together or the of the common iliac veins. Inferior vena cava then courses superiorly up towards the heart. But we do have some major tributaries, some major vessels that drain into that inferior vena cava that you have to be familiar with. So it begins, by the coming together of the common iliac veins. If you take it a little bit further distally or a little more inferiorly, you have the external iliac vein and internal iliac vein. So those two come together and form the common iliac vein. So you have a right common iliac vein, left common iliac vein. So that common iliac vein is formed by the union or coming together of the external iliac, which drains the legs. So this external iliac is bringing blood flow from the legs, basically all the way out to your toes, all the way coming up. Eventually, all those small veins we're going to learn are going to converge and come together, form the external iliac vein. The external iliac vein continues superiorly and then is met with the internal iliac vein. Those two come together, form the common iliac vein. Then the two common iliac veins come together, form the inferior vena cava and continuing superiorly. Major tributaries you have the hepatic veins, which drain the liver. They all converge and drain into the inferior vena cava. You have your renal veins then will also drain into the inferior vena cava as well. So your normal anatomy for the IVC, again, this is the major venous drainage. The common iliacs join or come together around the level of L5. So the inferior vena cava can be found anterior to the spine. So if a patient's lying completely supine, flat on the stretcher, the spine's gonna be posterior, IVC is gonna be anterior. It's located to the right of the aorta. And terminates in the right atrium. So this vessel continues all the way up, through the abdominal cavity, through the thoracic cavity, into and terminates and ends in the right atrium of the heart. In terms of its microscopic anatomy, the walls are thinner than compared to the arteries or the aorta, and it's under much lower pressure. IVC is very easily visualized in the upper abdomen if we utilize that liver as an acoustic window. So the liver is very vascular, has a good blood supply to it. So our ultrasound beam actually can penetrate the liver fairly easily if it's disease-free, and we can get nice pictures of the inferior vena cava as it courses posterior to the liver. So if you kind of think about it, this now, where this is a patient lying on the table, this liver is sitting anterior or in front of the inferior vena cava. The IVC is running behind it. So if this is nice and vascular, it acts as a nice acoustic window to allow those sound waves to pass through. We can image this segment of the IVC quite nicely by utilizing that liver as a window to be able to visualize the vessels. So it's a similar concept to how for female pelvic exam, they have the women drink water to fill their bladder. So that bladder acts as a nice acoustic window and allows the sound waves to pass through easily and be able to visualize those structures. So liver, again, acts as a nice acoustic window to be able to see the IVC in that segment. So something to just of note, we'll talk about this also in greater detail when we get into abdominal vasculature, is the gonadal veins. So, you know, in men, this would be testicular vein. In females, it would be ovarian vein. So here we just, you know, calling it the gonadal vein. So on the right side, the right gonadal vein, which drains, you know, either the male or female reproductive organs. On the right side, it connects directly into the inferior vena cava, but on the left side, that gonadal vein actually connects into the left renal vein. And then that then courses and brings that blood flow into the IVC. So it's just something to, you know, make a note of. This is just showing now normal inferior vena cava. So this is that proximal or superior portion where it's coursing underneath the liver. So here's your liver anterior to that inferior vena cava. And you can see the inferior vena cava coursing nicely posterior to that to the liver. So this is again showing that you can utilize your liver as a nice acoustic window to get nice pretty pictures for your inferior vena cava. So the IVC and respiration. So the diameter of IVC will change with respiration. So with inspiration now, when you take that deep breath in, the diaphragm's going down. So with this, the thoracic pressure is decreasing. This increases blood flow to the heart. But that blood flow, increased blood flow to the heart is coming from the arms. With expiration, when you're breathing out, the diaphragm's going up now. The IVC diameter will actually increase because thoracic pressure is increasing, abdominal pressure is decreasing, but we have increased flow now coming up from the legs. So that IVC diameters can increase now. Valsalva maneuver will actually cause the IVC to bulge. So with Valsalva maneuver, you're increasing both thoracic and abdominal pressure, but it's causing a cessation of blood flow, temporary cessation or pause of the blood flow, but this will actually cause the vessels to dilate. So Valsalva will cause IVC to dilate. Expiration will cause the IVC to dilate. Something that you're going to also notice is the closer you get to the heart with venous flow, the more pulsatile it gets. So we had mentioned, I think in our first lecture, we talked about the veins being continuous, or I'm sorry, phasic versus continuous. Phasicity showed that nice respiratory variations, those nice little rolling hills with the inspiration and expiration. And then if veins are pulsatile, that could potentially indicate congestive heart failure. So we could see those cardiac pulsations manifested in the venous tracing that we get. Something to also consider is your proximity to the heart. The closer we get to the heart, the more pulsatile those veins become, because we have cardiac influence on that venous system as the heart, and particularly the atria, contract and relax as they're filling and contracting. Those cardiac pulsations get translated back into the venous system, and we can actually pick them up. So it's normal for you to have some degree of pulsatility in the central veins. So IVC, if you're close to the heart, like maybe proximal subclavian when we get into the peripheral side, innominate veins. So anything close to the heart can demonstrate some degree of pulsatility, and that's considered normal. So you'll get the respiratory effects, the respiratory variations, and cardiac pulsatility for a lot of these central vessels. So hepatic anatomy now. So now we're talking about the venous drainage for the liver. We have three tributaries, that drain the liver. We have a right hepatic vein, middle hepatic vein, and a left hepatic vein. So each vein corresponds to a segment of the liver that you're gonna learn. Right hepatic vein drains the right lobe of the liver. So on the patient's right, middle hepatic vein separates actually right and left lobes. And then the left hepatic vein drains the left lobe of the liver. In terms of flow direction, we had two ways that we could describe flow direction as either being hepatopedal or hepatofugal. So last week you said hepatopedal means blood flow going towards the liver or into the liver. Hepatofugal means blood flow exiting or traveling away from the liver. So in this case, flow should be exiting the liver, draining out of the liver into that IVC. So normal flow direction should be hepatofugal. So the hepatic veins have a very unique Doppler waveform pattern, and it typically will form a W shape. And within that W shape, we could see systole and diastole, and then a momentary period of antegrade flow or flow reversal above the baseline. That's represented by the cardiac contraction. So this is that normal hepatic Doppler waveform. So it typically makes these little W's. So these two peaks correspond to systole and diastole, and then you get an atrial kick, where the atria actually contract and squeeze the remaining blood out of the atrium. And with that squeezing, some of that blood flow actually gets forced backwards into the inferior vena cava, so we can pick it up. So this is your normal looking hepatic vein waveform. So it looks unique. It's different from it's different from the other veins that we typically image. And then this was just now, I went back a slide. So this is just showing how ultrasound for the hepatic veins. So hepatic veins are easier to visualize when you're in a transverse imaging plane, where your IVC is going to be a circle. And here you can see left hepatic vein draining into the IVC down here, and middle hepatic vein draining into the IVC. We see a small segment or portion of that right hepatic vein going out to the right. This is now turning into a sagittal orientation where the vessel's running up and down. So this is superior, this is inferior, this is head, feet in that direction. And you can see the right hepatic vein now coming in and draining into that IVC there. So renal vein anatomy now. So the veins lie anterior to the arteries, so they're located above if you were to image sonographically. And coming from an anterior approach, and we're imaging this patient, you're going to see the veins sitting above or on top of the arteries. The right renal vein is shorter than the left. So if you just think about it, if the IVC is on the to the left of midline on the patient's right side of their body, that right renal vein just has a shorter distance to go. It doesn't have to cross over midline to get to that IVC. So it's shorter in length and extends directly into the IVC. The left renal vein, it's going to be longer in length. It's got a longer distance to travel to get from that left kidney across midline and then get into that IVC on the patient right. In terms of the left renal vein, it courses in between two vessels. So it's important for you to know. We're going to see this image sonographically presented a million different ways. You're going to get it in vascular, you're going to get it for sure in your abdominal ultrasound, your transverse midline picture at the level of the pancreas with all the vessels, and you're going to be expected to recognize and image, know what vessels you're looking at. So this kind of helps you to understand, that sonographic image that left renal vein courses in between the superior mesenteric artery here and your aorta. So aorta is going to be posterior to it or behind it. SMA is going to course anterior or in front of that left renal vein. So it's going to kind of be sandwiched in between the two. And when we get into abdominal vasculature, we're going to learn some different conditions that can occur, because you can actually wind up with compression of this vein between those two vessels and wind up with blood clot in your renal vein. So we had mentioned that we can also see on that left renal vein, the left adrenal vein also drains into that, as well as that left gonadal vein. So again, in men it would be the testicular vein, and women it would be the ovarian vein drained directly into that left renal vein. So there are a couple anatomic variations that do exist when you're talking about this anatomy. One of the common ones, or two of the most common, are either going to be a retroaortic left renal vein, meaning that left renal vein runs behind the aorta, or a circumflexor, circumaortic left renal vein, where it actually splits, and you get, instead of one renal vein, it splits, and one branch goes in front of it, and another branch goes behind the aorta. So this was an example of ultrasound now showing we have our aorta and your IVC and transverse, and then the vessel, the left renal vein, actually coursing posterior behind the aorta. So that's would be an anatomical variant. Normally it should be coursing anterior or in front of the aorta, and we should see the SMA there. So it should be in between those two vessels. So this is demonstrating that left renal vein running posterior or retroaortic. So in terms of the main renal vein, or the renal veins and their tributaries, so it goes in opposite order as the arteries. So if you can remember the arteries going from main renal artery to the segmental to the interlobar, arcuate, and then interlobular, we just kind of take it in reverse now. So everything is draining from the periphery now, draining, converging, coming centrally, and draining into that main renal vein. So now we're going to start with the very small interlobular. So these are little hairs in the cortex, or the outer portion of the kidney. So those interlobular veins drain into your arcuate veins, which come across the superior aspects of your pyramids. So these are going to be your little pyramids in your kidney. That's where your arcuate veins are located. So interlobular drain into the arcuate. Those arcuates will then drain into your interlobar. So you have your interlobar vessels running in between the lobes of your kidney. And then those interlobar eventually drain into your larger segmentals. Those segmentals then come together and form your main renal vein going out to the inferior vena cava. So system anatomy. So when we're talking about veins, we actually have three. Veins can be categorized into three different types of veins. We have deep veins, we have superficial veins, and then we have perforators or connecting veins. So these perforators actually connect your deep veins and your superficial veins. So in terms of differentiating the two between superficial and deep veins, the deep veins will always be accompanied by an artery of the same name. So when we talk about the brachial veins in the upper arm, we have a brachial artery. So we know that that's a deep vein because it's accompanied by an artery of the same name. Deep veins are also located within the muscular fascia. In terms of the veins, usually they are duplicated, meaning that there's two veins to one artery, particularly when you start getting further distal away. Superficial veins now do not have a corresponding artery. So that's something to just remember now. So we can differentiate superficial and deep veins by that accompanying artery. So if we're imaging a vein, we're imaging some vessels, if there's the artery in close proximity corresponding to those veins, then we know that it's a deep vein that we're imaging. If we don't see any artery with that vein, then we know that it's a superficial vein. Perforators are smaller, but these guys actually connect the superficial and deep systems. So kind of think of this as two kind of venous systems working, in tandem to bring blood flow back into the heart, and then eventually back to the lungs to get oxygenated. Deep veins lie deeper within that muscular fascia, have that accompanying artery. Superficial veins do not. They're typically closer to the surface of the skin, outside of that actual muscular fascia. And then we have the perforating veins, those connectors. So with the perforating veins, the perforators or these connecting veins, the flow direction or the direction of that blood flow within these vessels should be from the superficial veins into the deep veins. So if I'm imaging the patient and I have, the vessels on my screen, I see a pair of veins. So we said that typically these deep veins are going to be paired, meaning that there's two veins with a corresponding artery of the same name. If I see that artery, with those vessels, I know that these guys are going to be my deep veins. If I'm imaging a vein going down the leg and I don't see any artery with it, I know that that's a superficial vein. So if I'm saying I'm down here in the calf, I can pretend like it's either posterior tibial artery or I would say it's most lateral. So then we could say this is anterior tibial artery with the corresponding anterior tibial veins. We have two veins. We're going to learn that the GSV, of course, is all the way from the groin down the leg. So we can say that this is the great saphenous vein, which is one of our superficial veins. And then we have our perforator vein, which actually connects the superficial and the deep veins. So those perforator veins also help to drain the superficial system and get that blood flow back up to the heart. So blood flow is, going up in this direction, up the leg, trying to get its way back to the heart. We're going to learn about that. We learned a little bit about that calf muscle pump. So with the muscle contractions, it helps to squeeze this blood up the leg, up the extremity. And with that calf muscle pump, blood flow within these perforator veins should go from the superficial. So it should come up the superficial, cross that perforator and get into the deep system. So blood flow should go from the superficial into the deep vein, and then eventually up the leg. So perforator normal flow direction is going from superficial to deep. That's important when we start talking about reflux in these veins, is that flow direction. So the perforators flow direction should be unidirectional, going from the superficial veins through the perforators into the deep system. And then another thing that differentiates veins from arteries are these valves. So these valves are usually bicuspid, meaning they have two leaflets or two leaflets to that valve. And then the number of the valves will actually increase as you move more distally. So the further you get away from the heart, when you're talking about a vein segment, the more valves are going to be located or are going to be in that vein. This was showing now that venous anatomy. So this is superficial surface of your skin. You have your superficial vein and then a deep vein, and then that perforator connecting the two. So again, blood flow should be flowing up in this direction. Veins have these little valves. So these valves, again, are unidirectional, meaning that they want blood flow to just go in one direction. So as blood flow is moving its way up, these little valves will open up and then close. So they'll open up to allow blood flow to go through, and then they'll close with the pressure changes to prevent blood flow from going back down the extremity or down the vessel. So normal flow direction should be in the perforators up the superficial through the perforators into that deep system. That's your normal, should be your normal flow direction. Start with the number on it. So those perforators. So we have, in terms of the lower extremities, so really, we're only focused on the perforators for the lower extremities. There are perforators that exist in the upper extremities, but boards doesn't really test you on them. And in terms of clinical significance, we really don't assess the upper extremities for venous reflux. Uh, so venous reflux is what causes varicose veins. So when you see patients that have large varicose veins, it has to do with those valves becoming weak or incompetent and starting to leak and that blood flow flowing in the wrong direction. And it really affects the perforators, and we focus on the perforators and imaging those when we want to rule out the presence of venous reflux for patients who have varicose veins. So really, this is what we're going to focus on, is just the perforators for the legs. So this is going from superior or in the thigh, working your way distally towards the calf and the ankle. So you have the femoral canal perforators. They're also referred to as the hunter perforators. These are located around mid-thigh. The dods, working your way down, are located around the distal thigh. The paratibial or the voids perforators are around the level of the knee. And then down in the calf, you have the cocket or posterior tibial perforators. So Hunterin, Dodds, Boyd's, and Cockett. So some of the previous students came up with like a little mnemonic that said, hippies don't bite cheese. She was a vegan. So she went Hunterin, hippies, Dodds don't bite cheese for Cockett. So if you remember Hunterin, Dodds, Boyd's, and Cockett, and just kind of work your way down. Hunterin, mid-thigh, Dodds, distal thigh. So think like maybe adductor canal, Boyd's around the knee, and then Cockett down in the calf. So going from calf down to the ankle. This was showing the diagram of what those little valves really look like. So we said the valves are bicuspid, meaning that they have two leaflets or two cusps to that valve. And they're situated within a sinus. So that inner layer, that endothelial layer of the vessel, is where that valve attaches to and comes off of. Typically in the valve sinus, where that valve is located, the vein will actually enlarge a little bit. So you'd be scanning down the leg, you're scanning your vein, and then it balloons and opens a little bit or gets a little bit wider. That's typically going to be the site where you're going to have a valve. So some people, you could see the valves actually opening and closing quite clearly on ultrasound. Other people, it's very difficult to image and see those valves. So just something to just keep in consideration is where those valves are located also are nice places for thrombus or clot to form and start developing. When we get a little bit more into venous anatomy and venous ultrasound, we're going to learn about the different factors that lead to thrombus development. And one of them is stasis of blood. So when we get environments or conditions where blood flow does not circulate properly and can sit and collect and pool, that's what eventually forms blood clots. So when blood is stagnant and doesn't move, it congeals and starts to form into your thrombus and your clots. So in that valve sinus, you get a little pocket here where you can eventually wind up with thrombus formation. So that's just something you have to be careful when you start imaging and performing these DVT studies, is assessing, these valve sinuses for the presence of thrombus. So in terms of lower extremities, so we said these valves will open and close as a result of pressure changes. So in the lower extremities, these valves will open with expiration. So you're breathing out, that diaphragm's coming up. So lower pressure now in the abdominal cavity, that's promoting blood flow in the legs. So with your expiration, that lower pressure allows those veins to open up and allow for blood flow to move forward. With inspiration, those valves will close because now the pressure is increasing in the abdominal cavity, increasing the pressure, forces those valves to swing shut now. So again, with that increased abdominal pressure with inspiration now, we've decreased the amount of blood flow coming up the legs. So this is just here referring to lower extremity now. So if it was upper extremity, it would be reversed, it would be flipped. Alright, so veins of the upper extremities. So in terms of imaging for ultrasound, when we do image upper extremity veins and doing our protocol, we are gonna start with the internal jugular vein on the neck. So internal jugular vein is gonna be a deep vein, so its corresponding artery is gonna be your carotid artery. So even though these two, don't have the same name, internal jugular vein is a deep vein because it does have a corresponding artery. So in this case, the corresponding artery is that carotid artery. In terms of its waveform, it's fairly pulsatile, so it looks kind of similar to our hepatic Doppler waveform because it has very close proximity now to your heart. The next vessel that we image is going to be our subclavian vein. So this is also a deep vein now, has a corresponding artery. We know we have the subclavian artery, so we know it's a deep vein because it's got that corresponding artery that courses with it. This is also considered a more central vessel because we are in close proximity to the heart with the subclavian vein. So this one also typically has a pulsatile waveform as well. So of course is posterior and medial to the clavicle. And of course is posterior and inferior to the subclavian artery. So the artery is above it, vein is going to be below. So this was showing now on the left side, internal jugular vein. So you have your internal jugular vein. Again, now this is draining, the brain. It's the main channel of blood flow bringing back from draining the brain. We also now have the subclavian vein. So internal jugular vein and subclavian vein will actually come together and form your innominate or brachiocephalic vein. In terms of other vessels now. So subclavian vein will eventually, so axillary and cephalic come together, forming that subclavian vein. So we can see the axillary vein draining the axilla. So this one is also a deep vein because we have an axillary artery. Basilic vein and brachial vein come together and form that axillary vein. So again, everything is draining in that direction, coming from distal, out towards the fingertips, and we're working your way backwards. Some of the other vessels for our upper extremities, you can see cephalic vein and basilic vein. So those are going to be your two superficial veins or your main superficial veins for the upper extremities. Cephalic vein and basilic vein course down the entire upper arm. So we'll see that in some of the other pictures that we image. But those are going to be your two superficial veins for the upper extremities. So it's really not too hard to memorize your superficial veins for your arms. It's really your cephalic and basilic vein. Really, the only other one is your median cubital vein, where that actually connects your cephalic and basilic at your antecubital fossa. So we'll see that in a moment. Then we said deep veins for the upper extremities. They're always going to be accompanied by the artery of the same name. So continuing down the arm, we have the axillary vein. So the axillary becomes the subclavian at the upper border of that first rib. So this is, draining in the axilla. Once we get to the upper border of that first rib, the axillary vein becomes subclavian vein. So it's basically just changing name. Further down the arm, we have the brachial veins. So as the brachial veins cross that teres major muscle, it becomes the axillary vein. Further down the arm, we have the radial veins and the ulnar veins. So these are all deep veins because they all have corresponding arteries. So again, we said the radial veins are going to be lateral or thumb side. Ulnar veins are going to be in the forearm medial side or pinky side. The superficial veins for the arms are a major venous drainage for the upper extremities. So really we have two major, superficial veins in the arms or the upper extremities. We have our cephalic vein. So this one joins the subclavian vein near the distal end of the clavicle. runs along the lateral aspect of the upper extremity. So cephalic vein will start all the way down by the wrist, run all the way up the lateral aspect of the forearm, lateral aspect of the upper arm, come across and actually connect to the subclavian vein near your clavicle, the distal end of the clavicle. We do have that median antecubital vein or median cubital vein, which is in your antecubital fossa. So that vein actually connects these two vessels. That's kind of the nice juicy vein where everyone gets their IVs in or they draw bloods on. And then you have the basilic vein. So basilic vein will actually course now along the medial aspect of the upper arm. So it starts getting all the way down by the wrist. Basilic vein coming all the way up, all the way up, all the way up, runs along the medial aspect of the upper arm and actually joins the axillary at the border of the teres major muscle. So basilic vein is medial side of the arm, cephalic vein lateral side of the arm. And those are your two superficial veins. So here you can see now your superficial veins. So basilic vein all the way down to the wrist. So if I extended it out along the medial aspect, coming across. So this is now your antecubital fossa, you're bending your elbow. So this is that median cubital vein that connects your cephalic and basilic. And then cephalic vein courses along the lateral aspect of your arm. The lateral forearm, lateral upper arm, continues up, continues up, continues up, and then joins into your subclavian vein up here, just below your clavicle. So here you can see it now, cephalic vein, cephalic vein, cephalic vein. So this is that median cubital vein, you know, that is the connection between your cephalic and basilic there. So again, cephalic vein all the way lateral, lateral, all the way up, all the way up, all the way up, and then connects, you know, to the subclavian vein up there by your clavicle. Basilic vein, medial side, continues all the way up, all the way up, all the way up. And eventually, basilic and brachial come together to form the axillary. So here's a little piece of the brachial vein in the upper arm that we're not actually, you know, seeing in its entirety there, but just to kind of get an appreciation. That's a good picture, you know, stuff like this. If you can label stuff like that, you're going to be okay. And just some more diagrams showing your major vessel anatomy. So on here you can see both, you know, your right and left internal jugular veins. And you can also see some of the more central veins now as well. So you have your right and left brachiocephalic veins. So again, brachiocephalic and innominate could be used interchangeable, those two terms. So you might see some literature that refers to it as, you know, the right innominate or the left innominate. You might see some textbooks or literature that refers to it as the brachiocephalic. So you have a right brachiocephalic and a left brachiocephalic that come together and form your superior vena cava. So this is your SVC then draining into the right atrium of the heart. So your two jugular vein, your jugular vein and your subclavian veins come together to form brachiocephalic. So on this side, you have your left jugular vein, internal jugular vein, your left subclavian coming together to form your left brachiocephalic. The two brachiocephalic veins come together and form your superior vena cava. And some good practice. Two looks like right subclavian. 5 looks like your axillary vein. 6, your median cubital vein. So 3 is that lateral one going all the way up. So that's going to be your cephalic. 1 to your medial side. That's going to be your basilic. 4 looks like brachial artery. I'm sorry, brachial veins. If you open up like the on D2L the PowerPoint, like you do have all these notes down here too. So you have the keys. So if you open actual the PowerPoint itself, it should be there. So what are your superficial veins for your arms? Two, give me the two. Basilic, cephalic, good. Balsamic, don't know. Yes, basilic. Basilic and cephalic. And the vessel that connects the two is your median cubital vein. Sometimes they just say cubital vein, so I'll accept all those answers. Median cubital vein, cubital vein. That's in the antecubital fossa. Deep veins for upper extremities. You have internal jugular vein. That's the subclavian veins, axillary veins, brachial veins, going into your lateral side. Radial veins, and ulnar veins. Yep. So jugular, subclavian, axillary, brachial, radial, ulnar. For the legs. So now we have the inferior vena cava. So we said it's comprised of the coming together of the common iliac veins. So the common iliac veins are formed by the external iliac and the internal iliac coming together. So the external iliac is really the one that's responsible for draining the legs. So it is important, when we worry about the potential for blood clots or DVTs to develop, affecting the external iliac vein. For the legs, the deep veins are a major route of venous drainage for the legs. And again, deep veins are always going to be accompanied by an artery of the same name. So in the legs, we have our common femoral vein, so also referred to as the superficial femoral vein. Currently, a lot of hospitals, or pretty much all of the hospitals now, have dropped superficial femoral vein and just refer to it as femoral vein. Main reason being is when we used to call it the superficial femoral vein, if it was positive for DVT or a clot, doctors would just look at that preliminary report, see superficial femoral vein, think it's a superficial vessel, because the course of treatment is way different if it's a superficial vein that's thrombosed versus a deep vein. Deep veins, they have to go, particularly this high up, have to be on anticoagulation, so they need that intravenous effort. Superficial clot, they might just treat it like maybe with some warm compresses, kind of let the body resolve it on its own. So making the mistake between a superficial and a deep clot this high up is potentially be, life-threatening. So that's why they dropped the name superficial femoral vein and just call it femoral vein now. And then we have the deep femoral vein or the profundus femoris vein. So we'll see in a moment these branches. All right, so now we're looking, at the patient's groin. So this is the lower extremity. We're high up now. So we have that external iliac vein, more superior. And then we have the common femoral vein. So if I had to draw kind of like our demarcation zone, I don't want to draw on here, but there's a ligament that kind of goes across right here, our inguinal ligament in our groin, that separates external iliac from common femoral vein. So this would be, your common femoral vein below the level of the inguinal ligament, and then above the level of the inguinal ligament is going to be your external iliac vein. That common femoral vein splits into your deep femoral vein, or that profunda femoris vein, and then your femoral vein or superficial femoral vein. So again, I like to just drop superficial from there, just call it femoral vein. And then this one you could call it deep femoral vein or DFV, or profundus femoris. So common femoral vein, again, at the level of the inguinal ligament. So above it is the external iliac. Below the level of the inguinal ligament, external iliac becomes the common femoral vein. Has a corresponding artery of the same name. We have a common femoral artery. Working our way inferior, we have the femoral vein. The femoral vein is the primary route of venous drainage for the thigh. As you move distally, it dives into that abductor canal in that distal thigh area. With the femoral vein, about a quarter of the population, it's actually duplicated. So meaning we have two veins with one artery. And then we have, again, the other branch of that common femoral vein is the fundus femoris, or the deep femoral vein. Working our way further down the legs, we have the popliteal veins. The popliteal veins are a continuation of the femoral vein. So that superficial femoral vein or femoral vein continues down the thigh. Once we get to the level of the knee, it becomes the popliteal vein. So it's the same vessel, just changing names. The vessel lies posterior to the artery. And in about 25% of the population, it's duplicated. So this one, you can also potentially have two veins with one artery. Continuing further down the leg, we see the anterior tibial veins branch off. So these extend almost straight laterally from the popliteal vein. These vessels are paired. So that means that there's going to be two veins with one artery. And then we also see the tibial peroneal trunk. That tibial peroneal trunk will give rise to your posterior tibial veins and then your peroneal veins. So we said the most medial are your posterior tibial vessels. So posterior tibial artery and veins are going to be most medial. Most lateral is going to be your anterior tibial veins, and then peroneal veins are going to be in between. So in terms of, between these two, comparing them, these are going to be more medial, these are going to be more lateral. All of these calf veins, anterior tibial, posterior tibial, and peroneal, are all they're all paired. So they're all going to have one artery with the two veins. So when we're imaging them in transverse, we're going to see it as, one artery, and then typically a vein on either side. So maybe something like that. So that's what I mean when they're paired. So we're going to have two veins with the one artery. We're going to see things like that, presentation like that. They're going to kind of almost look like little dumbbells almost. They'll be close to each other. They were showing down a little bit further down the calf now. So we'd have femoral vein coming down. Once we get to the level of the knee, that femoral vein becomes popliteal vein now. So this is coursing, we're behind the knee, posterior to the knee, we have the popliteal vein. Popliteal vein will then split into your anterior tibial and a short segment of tibial peroneal trunk. That tibial peroneal trunk then splits into your posterior tibial and peroneal veins. So this is what it means by paired. So we have the two vessels, two veins, and one artery kind of in between or central to them. So that's how you're going to see it now, on ultrasound when you're imaging. So paired. Yeah, popliteal can sometimes be duplicated, so we could potentially have two popliteal veins. Same with femoral vein. About a quarter of that population will have, duplicated femoral vein or a duplicated popliteal vein. So just be aware of that. So all of these are all deep veins now because they all have corresponding arteries with them. There's a couple more deep veins that you also need to be aware of, particularly when it comes to imaging and ultrasound. We have the gastrocnemius veins, and these join or connect or dump into the popliteal vein. They lie medial to the head of the gastrocnemius muscle. They're a little bit medial or laterally oriented. So gastrocnemius muscle, it's going to be your calf, one of your main calf muscles. So with these vessels, they both get their name with the muscle that they are corresponding with or they're embedded in. So gastrocnemius veins are within that gastrocnemius muscle, dump or join directly into the popliteal vein. And then we have the soleal veins. So these are embedded in the soleus muscle, which is a little bit deeper than the gastrocnemius muscle. With the soleal veins, they'll drain into, either the posterior tibial or peroneal veins. They could potentially drain into both. With the soleal vein, for whatever reason, they like to have this as kind of like the Jeopardy trivia question. It's probably, or it is the most common site for thrombus formation or DVT to originate in, or for thrombus formation. So the soleal veins kind of act like this little, almost like cavern or sinus where blood flow likes to collect and store. And then when the calf muscle pumps, it squeezes, the soleal vein drains into the posterior tibial and kind of ejects and pushes everything forward. So one of the most common sites for thrombus development is in the soleal vein. But both of these are considered deep veins. So just keep that in mind when you're imaging and get into your professional careers and you see clot or thrombus in these vessels, these are considered DVT. So these are both deep veins. They will both have arteries corresponding with them. The soleal artery is very, very small and tiny. Gastrocnemius vein and artery are much easier to visualize. This was just now showing the large popliteal vein and then gastrocnemius vein draining into the popliteal. So what it would see, it's a little more superficial, closer to the surface of the skin, but it has a direct connection into the popliteal vein. So this was an angiogram now, showing gastrocnemius veins and soleal veins. So soleal veins are going to be further down in the calf. So think maybe around mid calf is where we see those soleal veins. Gastrocnemius veins, they run down the calf, but they originate higher up and eventually dump into the popliteal. So this is down around mid calf where we see the soleal sinus or the soleal veins. Here we see the gastrocnemius veins continuing up and then connecting to the popliteal more superiorly. When we get into imaging, the veins of the legs, soleal veins, they're going to be very, very small, particularly if there's no clot or DVT within them. Oftentimes, you're not even going to see them unless there's any, pathology present. So a good tech will kind of just take a quick look. We'll teach you guys how to, assess and take a quick look for the soleal veins to see if there is any DVT present. If they're negative and you don't see anything, then you typically don't even image them as part of your standard protocol. You kind of just take a glance, see if there's anything there, and then go back to your standard protocol of images that you're required to get. And this was just showing, its relationship. So here's a peroneal vein. You see much, much larger, and these guys are very, very small, very, very teeny in comparison. Again, soleal veins drain into posterior tibial and peroneal veins, whereas gastrocnemius veins drain into the popliteal. In terms of superficial veins for the legs, there's only two, so it's not bad. We have the great saphenous vein, or GSV, and then we have the small saphenous vein. So GSV is the longest vein in the body. Starts all the way up in the groin, where it connects into the common femoral vein. So it's typically just below the level of the inguinal ligament, all the way up in the groin, and then courses all the way down the medial aspect of the thigh, medial aspect of the calf, and goes all the way down towards the foot. So it's a major collateral root. Passes anterior to the medial malleolus and onto the foot. With the GSV, with the great saphenous vein, this is one of the veins that's oftentimes harvested or collected for coronary artery bypass surgery. So if a patient has a bad heart and you hear them, oh, I had triple bypass or quadruple bypass, they oftentimes will take and remove the patient's great saphenous vein and then use segments of that vessel to get around arterial blockages in the heart. So if one of the arteries is blocked, they'll take a piece of this vein, get around that blockage to bring blood flow to, areas of the heart that are infarcted or not receiving enough blood supply. We can also use this vessel if a patient has peripheral arterial disease. So if one of the arteries in the legs is blocked, they could take this vein now and turn it into an artery. So we're going to learn there's a couple methods and options that they can use, and they can use this vein now as an artery or as a conduit to bring blood flow, arterial blood flow down to the legs. So, those tissue beds aren't, necrotic, or they don't receive enough blood flow for patients, who are diabetic and have peripheral arterial disease. So it's often used for harvest for bypass surgeries. You could live without the GSV. We're going to learn when we get into more of the venous stuff that, this is one of the main culprits for reflux or insufficiency that leads to, varicose veins and venous stasis. So patients who suffer from really bad varicose veins, they'll either ligate, strip, remove, or now they like to use either radio frequencies where they actually ablate the vein, or they put in some chemical material that actually scleroses and shrivels up the vein to try and improve patients' quality when they have really bad or severe varicose veins. The other superficial vein in the leg is the small saphenous vein. So this one empties into the popliteal vein. So GSV empties into the common femoral vein. Small saphenous empties into the popliteal vein. So this one is pretty much just relegated, or it is just relegated to the calf, unless we have any sort of anatomical variant. It's often referred to as the stocking seam vein because it runs directly in the middle of the back of the calf. So you think posterior calf just runs directly up and down the middle of the back of the calf and empties into the popliteal vein behind the knee. Older terminology is referred to as the lesser saphenous veins, or LSV. So you might see some literature or older textbooks referring to the small saphenous as the LSV, or lesser saphenous vein. So great saphenous vein, lesser saphenous vein, or small saphenous vein.
Did you say there's GSV?
Up in the groin, the common femoral vein. So it goes all the way from the groin, all the way down the leg to the foot. So longest vein in the body. This was showing an ultrasound image now, popliteal vein, but that's lesser saphenous or small saphenous vein draining into the popliteal. So it looks very similar to gastrocnemius in terms of presentation. They're going to dump into each other kind of around the same area. They're both going to drain into that popliteal vein, but you can differentiate this one from your gastrocnemius vein by the presence of that artery. So when you're imaging, if you see an artery coursing along with the vein, you know that's gastrocnemius as opposed to the small saphenous. So you could see GSV and dumps into the common femoral vein all the way up in the groin, just below the level of that inguinal ligament. And it has a long course all the way down the leg. Whereas small saphenous, then sometimes referred to as that stocking seam vein, right along the back of the middle of the calf, and drains into the popliteal vein. Again, so if you can label, vessels that are on here, these are the ones I want you guys to focus on. The only really, maybe other ones I would add would be, this represents your inguinal ligament. So if this is common femoral vein here, what's above the inguinal ligament? So here's your IVC. External iliac. Yeah, so external iliac is just above, the inguinal ligament. It's not listed on here, but like internal iliac would probably be somewhere like in here. And then if you're above where those two come together, then it's common iliac. So we had talked, there are some, anatomical variants that do exist. Um. So we said about 25% of the population will have a duplicated either femoral vein or popliteal vein. So with that, we could see two femoral veins with the one artery. Typically, it's just one femoral vein coursing down the leg. You could have patients where they don't have an actual deep femoral vein. It's just one vessel continuing down where you don't actually get that bifurcation or splitting. So again, just realize that anatomical variants do exist. So when you're imaging, it might look a little bit different on one patient. So just realize that they may have anatomical variants. Some good practice. So 3 actually refers to this tibial peroneal trunk there. You take from the top, above the inguinal ligament, external iliac, below the level of inguinal ligament, common femoral vein. Common femoral vein then splits into your deep femoral vein or fundus femoris. Then you have your femoral vein coursing down the thigh, which is your root or your main pathway, main drainage for the thigh. Femoral vein continues down the thigh, becomes popliteal vein, the level of the knee. Popliteal vein will then split into your anterior tibial veins, which are again most lateral, anterior tibial, most lateral. You got your tibial peroneal trunk, which is 3 there. Then your tibial peroneal trunk then splits into your peroneal and posterior tibial. So 2 would be your posterior tibial veins. They're most medial. Peroneal veins going to be in between there, represented by 10. Then those are all deep veins. And then your only 2 superficial veins, you have 8, your great saphenous vein. And numbered under 1 be your small saphenous vein. All right, so in terms of microscopic anatomy for arterial wall. So all vessels will have 3 layers to them. We have a tunica intima, a tunica media, and a tunica adventitia. So a tunica intima is your innermost layer. It's thin, it's comprised of smooth endothelial cells and connective tissue. The tunica media is that middle layer or intermediate layer. So in terms of the arteries, this is going to be the thickest layer. It's comprised of smooth muscle and connective tissues. So this is, what gives that artery its stiffness and rigidity and its ability to handle those increased pressures. The outer layer is the tunica adventitia. So this is the most outer layer. It's comprised of elastic and collagenous fibrous connective tissue. This is also where the smooth muscle fibers are located. And then the last thing that I want you guys to know is that, vessels are living tissue. So they need their own, blood supply and nutrients. And the way that our blood vessels get their nutrients is from a network of vessels referred to as the vasa vasorum. So these are a network of small vessels that supply nutrients and blood flow to the vessels themselves. So these lie on the outer layer, that adventitial layer. The best way I kind of think about it is if you ever seen like those Christmas tree lights that like you kind of like they come and you just kind of lay them over your bush. Like that's kind of what it is. It's like this network of small little vessels that lie on top of the actual vessels themselves and bring nutrients into the vessels themselves. So this is, the inner layer, this is the outer layer of the vessel. So we get these small little network of vessels that kind of lie on top of the vessels themselves and bring nutrients and blood supply and oxygen into the actual arteries or veins themselves. So these exist in arteries, they exist in veins, this vasa vasorum. Vasa vasorum. Network of small blood vessels that supply the vessel walls with nutrients and oxygen and remove the waste product as well. So these are kind of like the microscopic, small little capillary system almost. Excuse me. Um, so in terms of the vessel walls now, then the vessel walls are going to be much thicker in the arteries, particularly that medial and adventitial layers when we compare them to the veins. So veins have the same layers, you know, they have the intima, media, and adventitial layers. Within these, again, they're much thinner compared to the arteries. They also have the vasa vasorum to supply nutrients to the vessels themselves. Because the veins have much thinner walls, and are under much lower pressure, we're actually able to collapse them or compress them compared to the arteries. Again, this is just showing artery and vein kind of side by side versus a capillary. So those capillaries are just that thin single layer of endothelial tissue. Whereas the veins and arteries have the 3 layers. So so I'm just going to kind of go briefly over some of the skills. So in intro to patient care, you guys are gonna actually be using old school method, that's a scope, and blood pressure cuffs to actually take some blood pressure measurements. So I just had a quick video on take some blood pressure measurements.
Investors, did you know that you can become your own bank? Yes, your own bank. You know what that means. No more stress about potential bank.
They can sign in on a computer at the room. Please use gloves while working with the mannequin. Use alcohol prep pads to sterilize earpieces before and after you use them. Insert earpieces at a forward angle and make sure chest piece is in the correct position. Place the chest piece on the circular area of the mannequin's arm. Make sure the valve is closed and use the pump to inflate the cup. Slowly release the air by making a slight adjustment to the valve. Listen carefully for the first carotid cough sound.
So with that carotid cuff sound, you will not hear anything with the cuff not inflated. So you're gonna inflate the cuff, inflate the cuff, inflate the cuff. And you're gonna hear the sound as you're inflating it, you'll start to hear the sound and it's gonna go away. You're gonna inflate again. Typically we'll do like, I don't know, for you guys probably don't have hypertension, go like maybe 180. And then we're gonna wait for that sound to return back. And that's gonna be your first systolic pressure, that top number.
When you're finished, pull the sheet up and clean up the area. Sarah?
So you'll start hearing the pulse. That's that first carotid cuff sound. So when you hear that pulse come back, that's your top systolic number. And then eventually that sound's gonna go away and that's gonna be your diastolic number. So you're listening and listening, looking at your gauge. Jen and I are gonna go over this too, in intro to patient care when we start doing it in lab. But you're gonna hear, you're gonna inflate, inflate, inflate. And then you're gonna slowly bleed it out and you're listening for that first sound to come back. That's gonna be your, the first carotid cough sound. That's your top systolic number. And then eventually it's still slowly bleeding. That sound is gonna go away and that's gonna be your diastole number, that bottom number. And then you're not gonna hear anything the rest of the way. And you can just, deflate the cuff completely. So I know a lot of times when they're first starting to take pressures, you haven't inflated the cuff, you're trying to listen, like, am I on the artery? Do I hear it? You're not gonna hear anything that way until it's inflated, actually.
Sterilize your earpieces and return the stethoscope to the cabinet. Make sure to.
You do have a sim lab at the Wilmington campus, so they have mannequins there
Tips and
that,
tricks
or you guys
to
can
access
utilize
in
to
the sim
practice
lab.
doing things like vitals, so measuring
Make sure
pressure,
your earpieces are
measuring
pulled
pulses,
forward
palpating
and
pulses.
otherwise, you will not hear anything. The valve needs to be closed, but not too tight, so you can easily loosen it to release the air. Make a slight adjustment to slowly release the air. Notice the steady, slow pace of the needle as the air is slowly released. This is the speed at which you should be releasing the air so that you can more accurately identify the first and last carotid cough sounds. A slight adjustment of the valve is all you need to slowly release the air. Listen carefully. The first carotid cough sound is the systolic blood pressure, and the disappearance of the last is the diastolic blood pressure. The more you practice taking blood pressure, the easier it will be and more confident you will become in this skill.
If you make at least 150 grand a year and you're
Wish. So in the lab, for this PVR SLP exam, some of you have had morning lab. We started in trying to locate, the dorsalis pedis artery. So this is just showing kind of, where it is, on, a cadaver, that dorsalis pedis artery. So we opened it up so you can see it coursing. So there's a flexor, extensor tendon, for the great toe in the foot. So if the patient points out their great toe a little bit, you'll see this tendon. And then, the artery is typically just, lateral to that tendon. So the tendon is gonna be medial. That dorsalis pedis artery is typically located, just, lateral to that tendon. So you can maybe sometimes utilize that as a landmark. You can also try and, again, always try and palpate and feel for pulses. Palpating dorsalis pedis artery. And then the other vessel we're gonna be looking for today in lab is, the posterior tibial artery. So in some of the slides, we mentioned that the posterior tibial artery courses posterior to the medial malleolus. So medial malleolus, medial, here's inner, malleolus is gonna be your ankle bone. So this is the, inner ankle bone, and it runs posterior or behind the medial malleolus is where we find that posterior tibial artery. So in the cadaver section, so here you can see that posterior tibial artery coursing, posterior to the medial malleolus. So that's where we're gonna be looking for that posterior tibial artery. So again, here you can also palpate and feel for that posterior tibial artery pulse and grade it. So is it a normal pulse? So is it bounding? Or is it very faint or very weak or absent potentially?
Hi, my name's Rob Daigle, and I'd like to do a brief demonstration here of the appropriate Doppler positioning for continuous wave Doppler that's used for acquiring blood pressures at the ankle or segmentally. Now, this again is a continuous wave Doppler, 8 megahertz transducer. We're going to evaluate the posterior tibial artery, just below the medial malleolus with a good blob of gel. I'm gonna put the transducer down and slowly scan towards the Achilles tendon until I find a Doppler signal. And then I'll go a little bit farther to try and maximize the signal and then sweep across the artery to get the sweet spot or the strongest signal that I can. Now you'll notice that I'm pointing the transducer up along the course of the vessel, not like this angle or not like that angle, which is not along the course, but straight up along the course of the vessel. And I'm holding the probe at about a 60 to about a 45-degree angle. That's a 90-degree angle, and the Doppler signal will be weak and the Doppler waveform will be inferior. And if we put some angle into this Doppler, then we'll acquire a better Doppler signal, a stronger Doppler signal as well. Now, perhaps on just on the skin here, I can kind of demonstrate that because this concave face right here is at an angle, it's not in full contact with the skin, we've got to use a pretty good blob of gel to get good contact along the posterior tibial artery. So don't hesitate in putting a good amount of gel to make good contact, holding it at these different Doppler angles. Also, you'll notice that my fingers are down on the skin here to help support the probe. It's important that once you acquire the signal to not move your hand during the pressure inflation sequence. Hopefully this demonstration about the correct method for holding the CW transducer will help you for acquiring ankle pressures and then also for segmental pressures if you accomplish that protocol.
So how to wrap segmental cuffs. So again, we want to use the appropriate size cuff. So what is the appropriate size cuff? So this is according to, vascular boards and textbooks. The cuff width should be at least 20 centimeters greater than the limb diameter, or 40% of the limb circumference. So I think that's one of the questions on your little lab cheat sheet or that we ask on the lab handout. You want to wrap the cuffs to fit snugly, so you can slip about only one finger in the proximal end of that cuff. And make sure that the tubes are not interfering with the site that you need to insunnate or listen to the vessels. So sometimes you might have the tube again running directly across the top of the foot. You want to kind of move the top a little bit, the tube over to the side a little bit so it's not interfering where you have to listen to. Tips.
Hi, my name is Rob Daigle. I'd like to demonstrate a technique for wrapping blood pressure cuffs, particularly with these cuffs that tend to be sort of uniform for physiologic testing systems. This is portion of the blood pressure cuff. It contains the bladder. This has the hose coming out. So this is the part that we're going to put towards the skin. The other part of the cuff right here is just essentially the wrap containing the Velcro. So trying to get these cuffs wrapped snugly is the real trick to applying these cuffs for physiologic testing for pressures and for pulse volume recordings. I start out by laying the bladder underneath the leg and then wrapping it around underneath towards the Achilles heel. And then I pull up on the remainder of the cuff in this fashion, kind of keeping the cuff snug. And then as I drape this part over, I keep pressure in my right hand to keep it snug. And the goal is to try and get this Velcro to catch without having the cuff loosen up. I continue to wrap around and here the Velcro catches. And I can continue the wrap. So that's a pretty snug wrap. On the outer layer here, it's still just a little bit overlap loose. If I can get 2 fingers underneath and slide this around, then that's too loose on the proximal end of the cuff. I can also then rotate the cuff a little bit to get the hose away from the posterior tibial artery right here. Again, I'll demonstrate this on the left ankle. Again, I bring the bladder up underneath the leg, bladder side. I wrap it all the way around, up underneath, trying to keep it snug there. Pull up with my right hand and kind of lay the cuff back over in this fashion, keeping it snug. Continue to wrap. So that's a pretty tight cuff wrap. So that'll make it easier for acquiring blood pressures and that we don't have to put as much air volume in the cuffs. And then it'll be a symmetrical tight wrap to acquire pulse volume reportings. I've already demonstrated how to wrap the ankle cuffs, and that same technique applies for the brachial cuffs as well. Now for the calf and the thigh, I'll use a 12 centimeter cuff width here. And we'll use that similar technique, putting the bladder portion up towards the skin and wrapping it around underneath, and then snugging it up so that we can get a good tight fit. I don't want the cuff to go up too high to overlap the bony structures of the knee, so just a little bit down distal to that. For the thigh, I'll start by wrapping at the upper thigh cuff as high as we can. Normally, we just have the patient's underwear on here so that it wouldn't interfere with the shorts. Often the patients will try and lift their thigh here or lift their entire leg to help you. But what happens is you put the cuff on snugly when their leg is elevated, and then they relax the leg and the cuff becomes loose because their muscles are relaxed. So try not to have them lift their leg to help you. Again, the same technique, try to pull up snugly on this and then wrap it down again and seal it. So that's the upper thigh cuff on the 4-cuff method. And we'll wrap one more 12 centimeter, or if we can't fit that 12 centimeter cuff here up on this thigh, if there's not enough room, then we use a 10 centimeter cuff. We'll try the 12 centimeter cuff on the lower thigh, or sometimes referred to as the above knee. So this patient has long enough limbs that we can get the 4 cuffs on one leg: high thigh, low thigh, above knee, or calf, and then the ankle cuff as well. Now, there's one other option for the thigh cuff, and that's in the 3-cuff method, using one large thigh cuff. This is a 17 or an 18 centimeter cuff. It's actually quite nicely designed in that it's conical in shape. So it fits and contours the thigh a little bit better than the straight 12 centimeter cuffs. You can see the conical shape here. And also this has 2 different Velcro straps, so it makes it a little bit easier to kind of cinch this larger cuff down. So this would be the 3-cuff technique: 1 thigh cuff, 1 calf, and 1 ankle cuff. One of the disadvantages of the large thigh cuff is it takes a lot of volume of air. So for segmental pressures, it sometimes is prohibitively time consuming to inflate this one single thigh cuff, but it works quite well for pulse volume recordings. So that ends the demonstration here on the appropriate way to wrap these cuffs. And hopefully this demonstration will help you.
So this is what we're practicing in lab. Again, we have 10 centimeter cuffs for the ankles and the arms, 12 centimeters for the high thigh, low thigh, and calf. And then we have that 7 centimeter metatarsal cuff that goes around the foot. Then try and arrange them after you're done in nice orderly fashion so it's easier for the next person, or if it's you coming back in to do another exam. In terms of bilateral placement, we're going to do, again, place cuffs on both sides of the body. We're going to place bilateral brachial, high thigh, low thigh, or above the knee, below the knee or calf, ankle, and then a metatarsal cuff. So this was now showing if we potentially did a thigh, a 3-cuff method with a single thigh cuff. This is our nice 4-cuff method. Again, can be also done for upper extremity arteries if we want to assess the arteries of the arm. So if we're doing the arms, we'd have our brachial, we'd have an upper forearm, a lower forearm by the wrist, and then we would use our PPG sensors to do digits, or we even have a small digit cuff as well. And just showing cuff placement. So for that lower extremity segmental limb pressures, we have to do bilateral placement. We're going to place again bilateral brachial, high thigh, low thigh, calf, and ankle cuffs. So for the segmental limb pressures, when we're actually doing the pressures, we don't have that metatarsal or foot cuff. So when it comes time to do the actual pressures themselves, we can remove that foot cuff. But when we're doing the pulse volume recordings, the PVR, we need that metatarsal cuff. So that's part of the PVR portion of it. So first part, pulse volume recording, we need the metatarsal cuff. When we get to the actual segmental limb pressures, we can remove that metatarsal cuff. Just one thing I just kind of wanted to mention about brachial cuffs. Not every person can have pressures taken in both arms. So that's something that you have to be cognizant and aware of when you get into the clinical setting. Oftentimes they'll have a bracelet on their wrist that says, do not use this extremity. Sometimes they may not. So it's always a good kind of practice to get in the habit of being, is it okay if I take blood pressures on both arms? So, there might be some patients that have, they might be undergoing hemodialysis, so they have bad kidneys, they have to go for dialysis treatments. And they'll have a fistula in that arm. So that arm is like, do not disturb. You know, like you do not want to do anything to damage or potentially affect that arm where they're getting dialysis from. So absolutely do not take a blood pressure in the arm if they have a hemodialysis fistula in that arm. Also, you might encounter women who've had breast cancer and they've had to remove lymph nodes on one side. You don't want to take pressures on that side where they've had the potential breast cancer or where they had breast cancer. Because you might disrupt or impact that lymphatic system that's very, very delicate right now. So they might have, you know, you might notice that one arm is very swollen, you know, so you can ask them in part of that medical history, you know, they'll know whether or not they can take pressures on that arm. So just again, be careful of it. They may or may not have that wristband that says do not use this extremity. So always just good practice. Hey, can I take pressures in both of your arms? Is that okay? Yeah, sure, it's fine. You know, they'll know whether or not, you know, to avoid that arm. Let's see. A little bit of a review. For the quiz, we got to know, be able to label vessels and describe them as being proximal or distal to each other. So I just kind of drew a heart here. We have our aortic arch. So, you know, we have ascending aorta, aortic arch. What's that first branch off your aortic arch? Anyone remember that guy? Say it if you know it. Brachiocephalic or innominate artery. So that first branch off your aortic arch, you have brachiocephalic, brachiocephalic, or be innominate. I'm sorry, what am I doing? Innominate. Those are the two terms. So brachiocephalic artery or innominate artery. So that's that first one. What else we got? So that brachiocephalic artery branches or splits into your right common carotid. Right CCA, right common carotid artery. This is gonna be your right subclavian. So if I was looking at this picture, right CCA is proximal or distal to brachiocephalic artery. Distal, good. Right subclavian would be distal to brachiocephalic artery. Should have drawn this down a little bit further. I kind of just took that diagram a little bit further now. So we have brachiocephalic artery on here. So we have brachiocephalic artery. Splits into your right common carotid artery, right subclavian artery. So in terms of right subclavian artery, you can then break this down into segments. So like here would be, proximal. Oh, sorry. Prox. You can have a mid. And then a distal. Again, you're slowly working your way further from the heart now. So that right common carotid then splits into, do you remember which two vessels they split into? Your common carotid artery? Yep, so internal carotid artery, one ICA and the other one being ECA. Can you recognize which one's which? I give a little hint. ECA will always have little branches that we could see. So ECA will have those little branches. That's gonna be your external carotid artery. ICA is gonna be over here, and that one's gonna be your straight shot back up to the brain. So this is gonna continue all the way up to the brain. We don't see any sort of branches extracranially, so it's just a straight shot up. ICA is typically more posterolateral. ECA is gonna be more medial in towards the face. So with this as well, we can have proximal, mid, and then distal segments. So, this would be prox ICA, mid ICA, and then distal ICA. So then just be comfortable, like saying that, like, I don't know, would be a good example, like prox CCA is proximal to, mid ICA, like just again, being able to, if I give you a segment of these vessels, being able to say which one's proximal and which one's distal to each other. Um. And be able to label these veins. So I'm gonna have some blank pictures like this on there to be able to label your major veins, ones we talked about. So subclavian, axillary, brachial. So again, if you could take one of these pictures, kind of maybe cover up and try and label them. I'm gonna have this for the upper extremities. I'm gonna have this for the lower extremities. Um. So again, with the arteries are not too bad. I mean, you know your arteries. So if you had, to label the arteries, you're familiar with the arteries, there's no superficial and deep arteries, so, you don't have to worry about that. In terms of the veins, I'll actually say, I'll mention either superficial or deep on there, or you'll see like, you'll see the deep ones labeled and you'll know you have to label the superficial ones. But I'll actually ask you, whether or not I'm asking for, a superficial or a deep one. So again, just be able to label the upper extremity arteries, the upper extremity veins, the lower extremity arteries, the lower extremity veins. So where's lower? Well, be able to label your lower extremity veins. Those guys. So know your inspiration and expiration, how it decreases and increases flow. So whether inspiration, for the upper extremities, inspiration with the lower extremities, inspiration for the upper and lower extremities. Valsalva maneuver, what it does, it decreases or cessation means a stoppage or a pause of the flow. So it actually pauses flow when you Valsalva maneuver in both the upper and lower extremities. So we talked about transmural pressure. So know your transmural pressure. Like if it's high transmural pressure, that's going to cause a nice big round circular vein. What is transmural pressure? So difference between that intramural pressure, the pressure inside the vein, and then the pressure outside in that, outside the vessel in that interstitial environment. So when it's very low, we wind up with a vein that looks very flat and collapsed, has a dumbbell appearance. When transmural pressure is high, that's when we have a nice circular vein. What else do we talk about? We talked about the veins being that reservoir of circulatory system. So it's referred to as the capacitance system, where about 60% or about 2/3 of the blood exists within the venous system. With the hemodynamic stuff, we talked about what we need for blood to actually flow within a vessel. So we need that conduit, we need a tube, so the vessel itself, and then we need a pressure gradient, a pressure difference in order for blood to move and circulate within a vessel. So without that pressure gradient, blood won't move, blood won't circulate. We need a pressure gradient and we need a channel for that blood to course along, which we have our vessels. Um, Anyone remember anything about Bernoulli's? Bernoulli's principle? Oh, Bernoulli. There's
It's the
Bernoulli's.
relationship between velocity and pressure.
Yeah, exactly. So Bernoulli's principle is the relationship between velocity and pressure. So they're inversely related. So when pressure goes down, velocities go up. So this is when we're talking about a stenosis or stenotic lesion. Mm. Then we talked about Poiseuille's equation. So this had to do with flow volume now. So this is really the equation that, you guys need to learn and memorize, for me and for your vascular board exams is Q is that Q represents flow volume. Delta P is your pressure gradient. Pi is just a constant, and then R is your radius of that vessel. And then all that is divided by 8, and then the vessel length and viscosity. So with that equation, really the most critical factor that affects the amount of blood flow going through that vessel is going to be your radius of your vessel, because that value is to the 4th power. So small changes in diameter of the vessel or radius of the vessel will have large impacts on the amount of flow volume within that vessel. The other factors that influence it are going to be the length of the vessel and the viscosity or thickness of the blood flow. So when these things are very high, that leads to very low flow volume. You put that in your equation, you have a very large denominator that creates a very low or reduces your flow volume. So if the blood's very thick, it's not going to flow as freely, leads to less flow volume in that vessel. If the vessel length is very long, you're gonna lose a lot of energy to friction of those red blood cells along the vessel wall, that reduces your flow volume. The things in the numerator have a direct relationship to flow volumes. When those are high, that's gonna increase your flow volume now. So when these are high, they decrease your flow volume. When things in the numerator are high, they actually increase your flow volume. So if you have a very large pressure gradient, that's gonna lead to increased flow. When the vessel radius is very large, again, you're gonna have increased flow. It's like filling questions, but I kind of give you some of the choices to fill in. Kinda, yeah. And then labeling, I mean, a good part of it is labeling. So in addition to the other labeling, you have to gonna label branches of the aorta, like coming down. I'm trying to see if I get a good picture. And the cerebrovascular labeling, so the vessels coming off the aortic arch. So, your brachiocephalic, your subclavian, your common carotid, internal carotid, external carotid artery, vertebral artery, and then the branches of the aorta. So, celiac artery, SMA, IMA.
About how many questions?
Let's see, there is 20 for labeling. And then it's got parts here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. There's like 12 fill-ins.
And then multiple choice.
No, not really.
Okay. Oh,
No,
okay.
no, that's it. Got the pictures. To arterial. So, yeah, just be able to label, your branches off the aorta. So you have your celiac artery. Celiac artery, we said trifurcates. We have our common hepatic, splenic artery, and then left gastric artery. So left gastric, we typically don't image it, we typically don't see. Common hepatic artery, we definitely do. That's that one wing of the seagull. Splenic artery was that other wing of that seagull going out to the patient left. Coming down inferior on the aorta, we have the superior mesenteric artery coming off the anterior surface of the aorta. You then can also see your right renal artery and your left renal artery coming off laterally. And then further down, more inferior, we have your inferior mesenteric artery. Per extremities. Again, just be able to, Label your arteries for the arms, arteries for the legs. Just those major guys that we were talking about. Again, if you can, label these guys, that's really only I'm expecting you to know. For these major ones. So again, the workbook goes very in detail about a lot of small little branches coming off the aorta, a lot of the small branches coming off the major ones. These are really the only ones that, the board's just gonna ask you about and that we're gonna be imaging, in the ultrasound lab. In terms of cerebral vascular, again, be able to label this. So this is a good example of, your cerebral vascular ultrasound. You have your aortic arch, your branches off the aortic arch. Your bifurcation of your common carotid into your internal and external arteries. So external carotid artery, again, you see that little branch coming off of it, that's the ECA. ICA does not have any branches, continues going up to the brain. So on the left side, you can see, left ICA, left ECA, you can see a little branch coming off there, it's the ECA. Then vertebral is a branch off the subclavian arteries, so you have a right and left vertebral arteries. In terms of your aortic branches, you have your brachiocephalic trunk or brachiocephalic artery or a nominate artery. Could all be used interchangeable names. Left common carotid artery and then left subclavian artery. Those are your three branches off the aortic arch. In terms of the circle of Willis, just know the major again. You don't need to memorize like all the little segments M1, M2. We'll go into that more in detail when we get into cerebrovascular ultrasound. But just be familiar, you have your internal carotid arteries feeding that anterior circulatory pathway. And then the ICA branches into your anterior cerebral. So you have a right and left anterior cerebral arteries. You have middle cerebral arteries going out to the mid portions of the brain. And then you have the posterior circulatory system that's fed by your vertebral arteries. Your vertebral arteries come together forming the basilar, and then you have right and left posterior cerebral artery. So you have anterior cerebral arteries, middle cerebral artery, and then posterior cerebral arteries. Those are the three. And then your communicating arteries. You have posterior communicating arteries, and then just that one little anterior communicating artery. So if you start now, try to memorize this stuff, you'll be, in good shape with getting towards the final. Because this stuff is going to reappear on the final. So there's going to be definitely labeling as we go. Pretty much.
Right.
Welcome to ultrasound. Told you, it's nothing like you've ever had at Delta. So see.
70?
7.
Girl. How does your grading work for these class? Like the weight of each.
Or quizzes. Quizzes are 10%, yeah. Finals 30, comps are 30, workbook is like 20. Do you guys want me to go over the workbook questions, like the answers? Make sure everyone's good with the answers. Maybe. Not workbook, the worksheets, sorry,
Yeah, sure.
worksheets.
Yeah, we tried them. I was actually gonna ask that. So yeah, we can go.
Yeah.
It's so on the schedule? The tests are the same as the quizzes, right? It's like,
Yes, yeah.
and then with the workbook, with it says like it's due, is there like? Do we rip the pages out?
You could take pictures of it
Oh.
and then just upload it to the D2L.
Right.
So I created like a little assignments tab on D2L where you could take a picture of it. You could scan it if you have a scanner, I don't know, like that. Whatever works for you.
So that's what we do with these worksheets.
The worksheets, yeah, that's just for you guys. They would not do them on our system. Alright, good, you're all getting your points. Alright, so vascular terminology is the first one. So anechoic. So anechoic describes a portion of an image that appears echo-free or have no echoes. So when we refer to something as being anechoic, it means that there's no echoes. So on ultrasound, that's going to appear as black on our screen. So anything that appears black, we refer to that as being anechoic or without echoes. Echogenicity, the term echogenicity means the levels of brightness or echo brightness. So again, everything in ultrasound is echoes coming back, it's sound waves coming back to our transducer, back to our camera. The strength of that echo determines its brightness. So echogenicity just refers to different degrees of brightness or different shades of gray. So something that's very bright is we refer to as being very echogenic, very bright. So use the terms echogenic, hypoechoic, isoechoic, homogeneous, heterogeneous to answer some of the following questions.
Are those, is that terminology on the test?
No.
No.
Not this.
I think it's in the intro class though, or other class.
Yeah.
Yeah.
So pancreas appears brighter than the liver. So the pancreas is echogenic to the liver. I would also take hyperechoic. So I didn't give that as one of your choices, but you can also use the term hyperechoic. I didn't actually include that in there. I should include that in there, to be honest. But when you say something is brighter, it's more echogenic. When something appears brighter, we refer to it as being more echogenic. So the pancreas is echogenic to the liver. You can also sometimes use the word hyperechoic, meaning it's a little bit brighter as well. The right kidney appears darker on the screen than the liver, so the right kidney is hypoechoic to the liver. That means it's darker. We use that term hypoechoic. So liver and spleen are the same shades of gray, so they're described as isoechoic. So that prefix iso means the same. So they're of the same echogenicity. We refer to as isoechoic. So then we have two terms, homogeneous and heterogeneous. So homogeneous or homogeneous means that everything is the similar echogenicity or similar echo texture. So a normal liver has a uniform soft shade of gray throughout the entire organ. We describe this sonographically as being homogeneous or homogeneous. Sometimes you might see on the milk, they refer to milk as homogenized. You pour a glass of milk, it's the same shade of white. You don't see like speckles of other colors in there. So that's homogeneous. That's what homogeneous means, homogeneous. Heterogeneous is kind of the opposite of that. So that means we have multiple different echogenicities and shades kind of all mixed together. And that's what we refer to as being heterogeneous. So a spleen has several cysts within it and a large hemangioma and two very dark areas. So instead of all being one echo texture, we got some cysts, which will appear anechoic and black. We got areas that might appear a little bit darker. And then we have the actual liver tissue, which will look brighter. So this would be described as heterogeneous. So when something's heterogeneous, think of that glass of milk and now I'm pouring in quick and I got clumps of Nestle quick swimming around in there. Then it's that would be a mixture of different echogenicities.
I have a question.
Sure, yeah.
Because I'm confused now. So I thought isocolor
Isoechoic, yeah.
was for like its surrounding, like comparing to the surrounding.
So you use it to compare like two different structures. You can use it to compare it to the surrounding as well.
And
So like,
homeostasis is not,
is within the organ itself,
okay.
like the structure itself that you're
Because
looking
I
at.
had flipped it thinking that, you know, saying it was the normal liver has uniform shape throughout the entire organ, so I'm thinking it's, I don't know. I just had flipped it to
Oh.
homogeneous and iso.
Yeah, throughout the entire organ
Yeah.
itself, so you're looking at that
Yeah.
organ in its entirety, are the echoes within that organ all the same?
Okay.
Does it look homogeneous? So like. This mug and this table are kind of isoechoic.
Mhm.
So you can describe this and that as being isoechoic, and like if I just had like, the shades of black there. The cup itself, like, without that would be homogeneous if it's all just black. If I just had a black mug with nothing else on it. But now I got pictures and stuff on there, I could say the mug is heterogeneous because
Right.
there's other colors in there. So cephalid, caudal, superior, inferior, anterior, posterior, lateral, medial, ipsilateral, contralateral, proximal, distal. So again, some more of that terminology. So some of these things we can actually use interchangeable, cephalid or cranial and caudal. So cephalid means up towards the head, caudal is distally towards the feet, superior, inferior. Can also be used kind of interchangeable with cranial and caudal. So there could be some additional multiple answers, a patient's feet are inferior to his knees.
Can we say distal?
You could say distal, the patient's feet are distal to his knees. Usually when we like use those terms like proximal and distal, it's kind of like that same structure or same vessel, but it could be used interchangeable. The liver is located superior to the kidneys. Again, you could use, cephalid to the kidneys as well. Usually proximal and distal, we kind of, you could use it for the arm, proximal arm, mid-arm, distal arm, yeah. Yeah, you could use that. Patient's head. So a patient's head is cephalid or superior to his chest. Liver is located posterior to the abdominal wall. So if the patient's lying there, supine on the table, you have your abdominal wall, and then the liver will be posterior. So we have anterior, posterior. Great vessels. So your aorta and IVC will be located medial to your kidneys. Your kidneys are out lateral. Great vessels are medial, midline. So medial refers to midline. Lateral is out towards the sides. The arms can be lateral to the heart. So contralateral refers to the opposite side of the body. So we use that term contralateral when we want to compare things that we have pairs of typically. So we have two arms, like right arm and a left arm. So one arm could be contralateral to the other. We have, two kidneys. So right and left kidneys would be contralateral to each other. Vessels, we have contralateral vessels. So when you want to refer to the vessel on the opposite side, it's contralateral. If you want to refer to stuff that's on the same side of the body, then it would be ipsilateral. So liver and the right kidney would be ipsilateral on the same side of that body. Bifurcation of the aorta into the iliac arteries. All right, so the bifurcation of the aorta into iliacs is distal to the thoracic aorta. So we have thoracic aorta up here, and then that bifurcation way down there. So that bifurcation is distal to that thoracic aorta. If you flipped it, thoracic aorta would be proximal to the bifurcation of the iliac arteries. So that would be, thoracic aorta would be proximal to the common iliacs. Common iliacs is distal to the thoracic aorta. Again, use that heart as your point of origin. So aorta is proximal to the common iliac arteries. Yes. You have your aorta, And common iliac arteries, common iliac arteries are further away, they're further distal. So another word for superior is cephalid, another word for inferior is caudal. So the aorta is anterior to the spine. In terms of your body planes now. So the one coming straight across like that to your sagittal or longitudinal plane. Cutting the body this way is your transverse plane. And then you have a coronal plane going this way, coming like from the sides. This is your coronal plane, your sagittal plane, and then your transverse plane. And some more body orientations. So this body orientation refers to away from the center line, midline of the body. So this would be lateral. So anything that's away from that center is referred to as being lateral. Body orientation that refers to closer to the point of attachment or origin of the vessel. This could be proximal. Body orientation that refers to towards the center line of that body, the midline, is medial. That's midline medial. Body orientation that refers towards the head is going to be cephalid. Body orientation that refers to further away from the point of attachment or origin is distal. And body orientation that's towards the feet, so there's a little bit more, reinforcement is going to be caudal. So screen orientation in a sagittal plane. So now we're in a sagittal plane. The left of the screen is going to be superior. There. Screen. You got a vessel going across. On the sagittal plane, the left of the screen, so over here, left. This is the right side of the screen. So this represents superior. That side, this is going to be inferior if we're in that sagittal plane. So we said the left side of the screen, so I'm kind of starring the left side of the screen. Always represents like the notch on your transducer. So every transducer is going to have that notch on it. So when we're in a sagittal orientation, this represents the notch on this side of the screen. This is where our notch is going to be. I'm just going to kind of right in there. That's the notch. So if I have a vessel running up and down like our aorta, this is my notch is on this side of the screen. So I'm seeing this part of the aorta, the most superior portion of it. And then the other side of the transducer is going to be over here on the right side of the screen. That's going to be the inferior portion or distal. Well, I don't want to say distal, but inferior portion for that aorta. So the notch is always going to be represented as this side of the screen. So that's going to be our sagittal orientation. First, pick an eraser to put on here. So then when we rotate in a transverse plane, that notch now is gonna be rotated towards the patient's right. So if I'm scanning and I'm on the right side of the patient, we're rotating that notch towards me 90 degrees. So I'm taking that notch, rotating towards the patient's right now. So now that's gonna be my imaging plane. Now I'm seeing that vessel and now as a circle, if I'm using that aorta as that example. So now the notch, again, we said that this side of the screen is always gonna be your notch. So that's your notch, start. So now the notch represents the patient right. And the other side, the transducer represents the patient left. So in terms of, what we're seeing on the screen, this is right side of the body. And this is now left side of the body. So anterior posterior still hasn't changed. So this is still the surface of the skin. This is still anterior. And this is still posterior. But none of that has changed at this point. So in sagittal and transverse, it's always gonna be anterior and posterior. Yeah.
The right and the left that you just.
I'm just the right and left side of the screen. I'll erase those. So this is the left side of the screen, this is your right side of the screen. Yeah, you can erase those. So this would be transverse. TRV, transverse. So in terms of some of those terms, closer to the probe would be superficial. While deep is further away from the probe, so you can use those terms superficial and deep there. Again, the term interchangeable with cephalid would be superior. Interchangeable with caudal would be inferior. Again, you can swap those terms out, inferior, superior with cephalid and caudal. Then your proximal relationship. Again, fill in proximal and distal. So right subclavian is blank to the right axillary artery. Right subclavian is to the artery. Proximal, that is. Superficial femoral artery is blank to the common femoral artery. Distal, good. Left common carotid artery is blank to the ascending aorta. Distal, good. Oh, back here. Radial artery is distal to the brachial artery, good. Popliteal artery, proximal to the peroneal artery, good. Abdominal aorta is blank to the external iliac. Proximal, good. Ascending aorta is blank to the abdominal aorta. Proximal, yep. Posterior tibial artery is distal to the common femoral artery. That's it, right? Yeah,
Some of those will be on the Texas, right?
like that, yeah,
Yeah.
yes.
So for number 8, you would have accepted superior, or you would have accepted,
Like caudal.
um,
Or so, I'm sorry, Savalid, yes,
Yeah, okay.
superior Savalid, yes, or inferior caudal, yeah, you can use those terms interchangeable.
so if we do memorize this, we're good for the artery for the chart.
Maybe, what are we missing? Missing anything on here? Well, like the branches of the abdominal aorta, so like from celiac, SMA, INA. It's like the esophagus, esophagus,
Right.
Um, some of the ones, like off that PowerPoint, like
Okay.
the ones I've like, look at this one. Um. Again, I'm not here to trick you guys.
Yeah, where's that homework tab?
Yeah, it's under assignments. Activities, yeah. Not make it accessible. They can- Activities, assignments. They didn't copy over, huh? All right, I will create those tabs to upload the workbooks, sorry. Let me course copy it. I thought I was good to go. So, just put those tabs in here. Anyone else have any questions or things you want to go over?
Everything.
That's
That's everything.
pretty much it. Yep.
Memorize.
Make flashcards, make partners, make study guides, I don't know, buddy up. It's my advice. With your friends.
No, we're no longer like, we're getting mind over it. I don't know about that. I'll mind that.
Oh, really?
Do you need me to come in like at a different time than the test, or should I just come in the following Tuesday?
Yeah, you can take it after class on Tuesday if you want, or if you want to do it, it's up to you.
Yes, thanks.
Okay. Do 618. 716.
After this stuff that are like, what's that? The learning to was I watched the slides or the lectures, and as I was watching it, I would just make like Quizlets. That's what I did. So then I could like look back at that, because it's kind of hard to write notes. It's like you don't even write the whole slide down, it's already there. So I was like, okay, maybe I should distance, that's what I did.
Yeah.
It helped in the last like couple of tests, but. I don't like fully the basic classes because then I thought. Yeah, I know, like it makes it so much harder for you to do like. I guess it would be like, like it's not like I want to sit there and watch this recorded lecture. Yeah, I feel the same way. I feel like this, even though it's a little bit of more. Like everything is new, but because the way it's like. I think it's here, this is what you can tell, this is it's like easier. I also just like being in person. Yeah. Like, I'm not doing COVID, I'm just not on. I would took, a class, like, it's the longest night, and just like taking it, it's like way much easier. Yeah, I was in high school when, like, COVID hit, I was a sophomore, so I didn't go back until only my senior year. But during the COVID learning, I did so bad. And I was like, literally, my first 2 years of school, I had a 4.0 and then a 4.25. Yeah. And then junior year, I managed to get like a 3.6, which isn't bad, but it was like really bad for me. Yeah, because like I just didn't do anything. The only reason I got a 3.6 was because I was taking AP bio and I got a C in it, which was technically a B. So my grades weren't that bad, but yeah. And then senior year, I had a 4.5 again. And I was like, I literally ended with like a 3.99 something. Yeah, honestly, we're freaking COVID. I just prefer Zoom to be honest. It's like it's hard for me to see, I could not do Zooms because I would get so bored. I had my physics class through Zoom and I would just sit there like. Should they record them? So yeah, the recording, right? Yeah. She was like, yeah, when I was no, during my camp, but I had back on 2 other kids that are like 3. During, I would be like supermarket. I don't remember I don't remember what her name was, and I didn't really take up with her. But she kind of got on my nerves. She just talked really, like, I didn't enjoy her. Did you last semester? You took it or no? 2 semesters ago. Okay, I forgot. I had the one that had the cat. No, I remember what her name was. I took mine. I was drawing a blank on it. I took all of my. I was taking the same teacher because her cat would show up a lot. She was like liner. Yeah, she did. Oh my god. Yeah, she was in one. I think I had her too. She's the one that also was like it's a comedy. Yes. Yes. She was good though. I love her. She was nice. Yeah. She was funny. She was really funny. All my prereqs were this. She had an Irish last name. I took physically. Yeah, and she like spoke German or something. McDonald, but that was it. I did it. I think it was McDonald. Yeah. I think she was a little. Yeah, she talked about her daughter. Yeah, she was pretty. Yeah, and when I started at University of Delaware, like my freshman year of college, I guess it's second year, junior year now. To say that. So my second semester, I had like already figured out that I would transfer into the ultrasound program. So I was like, well, I guess I should try to like get these like prereqs out of play. So I took like a stat class online. Like 3 out of my 4 classes were online. I really only had 1 in-person class. Yeah. So I was in my dorm like all the time. But like half the time, my stat class, I figured out that it was really easy for me. Because I didn't think I was really good at stat, but it was honestly just like a lot on the calculator and a lot of like formulas, which I thrived with. Yeah. So I figured out that I didn't really have to pay attention. And it was early in the morning. So on the days that I wouldn't have to do a group assignment or like take a test, I would just turn the Zoom on and go back to sleep. My roommate took a picture of me. My computer was like sitting next to my bed, like half closed, but half open, and I was sleeping muted, and I'm just dead asleep. I literally passed that class with like a 99.
Yeah, oh, wow. Sorry.
And then I took language and medicine online, which is like the medical terminology class here. It was so bad. My professor was this, like, I don't know, but her accent was so thick. So I would sit there and like, no offense, but half the time she couldn't even pronounce the words right. So I'm like, how am I supposed to pronounce it? Because half the class was about pronunciation.
Yeah.
And so I'm sitting there and I just literally could listen to her and she just lies through this stuff. And I'm like, oh, it was so bad. But I was like, you know what, I gotta have a way. I was like, I'm not taking this again. Yeah. So I went to it was during COVID and I was like all online. So I could mine was all online, but I would have to go even to testing center at UB, take all my tests. I did 65, but I still passed with I don't want to hear it. I'm done.
Wait, I'm taking mine, but it starts maybe. It's on.
It's an easy one. It's pretty, honestly, like after you take anatomy and stuff like that, it's pretty self-explanatory. Yeah, the only reason that it like sort of helped me for anatomy, because like I kind of knew what half the stuff I don't. Yeah. Yeah, a lot of the stuff we just don't. Really, we all of you learn stuff, else, crossing, just because of the way. But I didn't put in any assignments. Yeah. I took it.
Is it waste?
I took it easy.
Stop it.
Honestly, I think we get all that we need in the anatomy courses.
Okay.
That's my personal. I think that is good one as well. Yeah, I really don't, I really, that class is more of a headache for me than help. Especially
Opinions?
I have it now.
Because the college is on my case about trying to cut credits for the program. That's like their big, huge initiative now. They're like, oh, your program's way too many credits. You gotta get down to 72. I'm like,
What are we at?
72, like how? Davis is 83, CBS is 85.
If anything, probably flat medical terminology, because honestly, I don't really think.
We're looking at that. We're looking at, disease processes.
I feel like it's more for like a doctor.
Right?
Because a lot of
Yeah,
the stuff we
so-
need to know are covered in the bio classes. Yeah.
And we're gonna cover here, like, when we get into abdomen, OB/GYN.
We cover it all here, and then in anatomy, honestly, anatomy was like all that I needed.
I just feel like also the format of that class is what's making it a little bit, like, cause it's offered consistent.
Because it's just online,
Yeah.
so you just sit there and watch like a 3-hour lecture that really makes absolutely no sense.
Yeah.
And then they're like, okay, take a test.
And then a lot of the tests were so outdated that there were so many wrong stuff, and then through the semester, they revisit that.
Yeah.
I was like, I really don't need this.
One of my CBS students just took it last semester and like, you know, she'd gone through all the vascular and echo stuff and like. When it got to that point in the chapter, she would like fly through the test and the teacher was convinced she was cheating. And like she would finish the test in like 15 minutes because it was all stuff we had to learn in and out.
Yeah.
And she was like, it was wrong, like what she was teaching the class was just like flat out wrong.
Yeah.
So she was correcting the teacher.
Honestly, the professor that I had for that class, it was really hard to listen to the lectures because she just like kind of blanked all the time. So I'm just sitting there and then she would just like stop talking or just like stutter over all of her words and then she wouldn't make any sense and I just stopped. Like, I don't know what you're saying. But I just took it.
Pressure we need to do in the next month is come up with a plan to cut credits. But I'm gonna,
The tests were kind of hard.
incentive. It's me, but I'm taking a hard stance and just being like, no, I'm kind of like being the one, the guinea pig to see what happens. I'm like, no, I'm not doing it.
Honestly,
'Cause,
those are
like-
the only two classes I would consider.
Yeah, I mean, it's not gonna affect any of you guys, because you guys are kind of
Oh,
grandfathered,
yeah.
whether the courses are, be like,
But like,
classes coming in,
I couldn't see it.
but like,
That way, like, everything else makes sense.
the problem is like, our core courses, what they're weighted, like in terms of credits, do not equate to. Like a 2 and 3 credit class here is like probably 5 or 6 or what it should be,
Yeah.
you know? In terms of the information, what you covered, the lab, lecture component to it, it just doesn't make sense that they're giving me, you know, 3 credits to teach all this stuff, whereas like AP is 5. So like, so they gotta adjust on their, end, and that's my hard stance that I'm taking, like, I want more credit, I want more time, more stand, I need
Yeah,
more
because
to prepare you
It
guys.
doesn't make sense to be like this.
Yeah, or the topic ones, like, God bless you, like, those
I
are like
saw that.
2 credits, like,
I saw that and I was like.
no way.
I was like, that doesn't, right?
Like, yeah, that's like. Too bad, it's nuts. The abdomen and OBGYN classes, 2 credits, like. It's insane, I know. So, but I don't know, so we'll see what they say. Like the old program director, Lily, I talk to her all the time, she's like, what are they doing? Like, don't they understand, like, why do they do that? Like, what are they doing? They don't understand. And the other thing too is they want me to strip vascular completely from the DMS degree. Because if they don't offer it at Georgetown, because they don't have the licenses that we have to kind of conform to them. Because it's not equitable or fair for those students down there. I get it, like, all right, but we're 2 different programs. Yeah, but we're 2 different programs. That's what they don't understand. We're 2 different degrees, we're 2 different licensures. Like, everything is separate. Like, our budgets are different, our deans are different, like, think of it as like 2 different colleges, Wilmington and Georgetown, if you want to look at it that way. Like, I'll change the name of the program, but there's no extra vascular. Like, they're basically like, no, you have to do it. I'm like, all right,
It's not.
I'm not going to.
There's only 4.
Playing chicken right now at the college.
It's not like you have like a ton of students.
No.
It's a highly sought after program.
Like, then I would be graduating 4 RVTs for the entire state and everywhere, like, there's no way, like, to meet the demands for vascular techs, like, they're urgent, they need vascular techs, they need echo techs, like that. I'm so box right now. Just bad. We do this best for this. All right. So we are going to go through an entire exam. We're gonna do the whole segmental limb pressures, we'll do 1 leg. Did you guys practice on finding dorsalis pedis artery, posterior tibial artery, getting the pressures? These were some patient, like mock patients, if you wanted to practice, like, you know, picking a patient and then like pretending to be that patient and putting in the information or how to obtain information. So this is kind of good practice if you wanna pick a patient, practice.
Did you grade it?
No, it's not great. This is just practice. We're just going, no, we got like 4 weeks until we actually do a competency. No. No, this is just practice time. This is your last time, your practice time. Getting comfortable doing the exams. You
I'm gonna grow, she's like a half.
like Rose? Rose is popular.
I like that. Yeah, Rose only weighs 108 pounds. It's fine. I wonder if she up for a 10.
They're wondering if that's the metric.
Is it an invention?
I don't know. I don't think I put it here, but yeah, I have one.
Oh,
You got there, you go.
I'm unable to answer a question. Score. I know, I'm. Well, I'm going up to Maryland, but Maryland's like a 60% capital. I have like things. It's cheaper in Delaware. Yeah. So Maryland has like a really big tax. It's like 60%. Yeah, maybe it's right.
Yeah, authorization. They roll it wrong or whatever. Gonna be our first victim this week. First big shot. Yeah. This guy. Okay, so you study. You're ready. Hold on, what brought you in today?
Oh, right, like,
Have a red leg pain. Where in the leg are you feeling the pain? Half, ankle, all right. Whole leg,
the whole way.
whole red leg, okay. Verify for me again, your date of birth. When you put it, and the patient. Once a, put in your information. Maybe tag team. History. Since you've been here, we have some of our notes already. It's nice when the patient's been here. But if we didn't, smoking history, so. Ms. Bird, do you smoke or do you currently smoke? Smoke in the past previously? When you were smoking, how much did you smoke? How many years? 50. Good God! 50 years, okay. So, previous smoker, back at 8 years. You can ask him if you want how long it's been since they quit, sometimes, that plays into it. Then, do you have high blood pressure or do you take any medications for high blood pressure? What about cholesterol? Do you take any medications for high cholesterol? Do you have high cholesterol? Are you diabetic? Do you take medications for diabetes? Do you feel any pain or cramping in the legs? So now it's claudication again. Feel any pain or cramping in the legs when you exercise or walk? Which leg? Right leg, left leg? Then you ask me where do you feel that cramp? Calf, ankle, your thighs, buttocks. Do you feel any pain at night when you're resting that wakes you up in the middle of the night? Right leg as well. Like gangrene ulcers, you're looking, do you have any wounds or ulcers anywhere that I'm not seeing? Wounds, ulcers, skin color changes, you look. Skin color changes, you're looking, are the legs very bright and red, or do they look very pale? So pale is pallid. Do you see any evidence of cyanosis? Purplish or bluish? Have you ever had, an angioplasty or endovascular surgeries, you know? Have you ever had a stroke? Have you ever had a heart attack? Right, here you go. Even though that's not listed on your MI, it's another important thing, because gas is, myocardial infarct. For heart attacks, so MI is, myocardial infarct, that means heart attack. Yeah, that's enough, that's a medical term for heart attack, it's an MI. Yeah, so CVA is cerebrovascular accident, so that's a full stroke. We're gonna learn about, there's different types of strokes, you have like the mini strokes where you have a symptom, they go away within 24 hours. CVA is a full stroke with permanent neurologic deficit, so those are patients, after they've had a stroke, they have like permanent either paralysis or speech thing. Vision, weak on one side, like a permanent facial movement. Patients who have sickle cell anemia sometimes have a stroke at an early age too. Yeah. After history, and then we're gonna do our, again, test select on. What's the first test we do? Yeah, BPR for a pulse volume recording. All right, let's cover up. Get some gloves on, rock and roll. Oh, I got some larges over there, I got some mediums and smalls over there. All right, yeah, go for it. I'll see if I can hear some. Keep it up, Johnny. Down underneath the limb. Very good. This one actually has to go up. Yeah.
10, and then.
Yeah, ankles and arms 10, and then 12 everywhere else. 12. Yep. I like to keep the tubes all pointing down. It kind of just keeps everything uniform, particularly when you're trying to connect the tubes. It's easier to find. Yep, underneath the leg. Oh, I got you. Got it. I think the odds of issues with like college classes, professors, I mean, all of more free. You're all not my students, but I will, unfortunately, every one of you, please graduate. Red for the patient, right? Yeah. Right for the patient, left. Perfect. Yellow for left. White tube is for the brachial. Yeah. Right, or you can look at your cheat sheet on your screen. Grab your colors. It's on there as well. So yeah. I'm gonna take yours. Yeah. Start. We always start this part with the arms. You set it for the arms in terms of size, scale. And once the arms are set, you don't change the size. The hair size is kind of set to nothing, so that's probably gonna be pretty good. Now I just explained to the patient, all right, so I'm gonna begin with, the cups in your arms. They're gonna, inflate simultaneously, you'll feel both sides inflate at the same time, you know. This part of the test is very sensitive to motion, so just try and stay as still as possible. After the arm, we're just gonna slowly work our way down the legs, you'll feel both cups inflate at the same time. And then you'll feel in the opposite direction, take pressures. Bottoming out. Just over, yeah, so lower the size. I can see it. Yeah. This one, it's on your remote as well, if you want it to. You have, size. Actual. Right now, we're at like 70. So this is the pulse volume reporting. So this is measuring, volume changes of blood flow in that segment. So the pulse displaces some of the air in the cup and creates this tracing. So the less blood flow coursing through that segment, the worse this is gonna look. It's gonna start looking flatter, more rounded. We're gonna lose this dichromatic notch where it bends back. But we're gonna learn this all in class. We're gonna have a whole two lectures, of just looking at me for, is there disease, yes or no? How significant is it? Lectures like that, it's nice. Um, little trick on here. Like that, jawline. Yeah, it's a small. I would try and cook the size. Good size.
That's the first one, and then the rest is it by itself.
It does, so. About panic things, yeah.
It's not just for veins, they're just like along the veins.
So above and below the baseline shows the direction of blood flow. So I like to keep the veins kind of below the baseline and then arteries above the baseline to kind of show flow direction to the doctors. So with that hepatic veins, there is a momentary period where those atrial contract where it goes in the opposite direction. So normally it's flowing into the IVC back to the artery.
Okay.
But the atria actually squeeze into that final bit of squeeze that pushes some backwards. You see it above that baseline. But yeah, the baseline just shows the direction at which you will towards or away from. But in the arteries, when you have triphasic waveforms, the blood flow is actually going forward, backwards, forward, like pretty slow to your
Yeah.
It's actually doing that in the arteries. Or increase, decrease, the expiration, just flow to the whole period to decrease or decrease, Pressure, like, so those kind of things, like, just like decrease,
I will, yeah.
think about finally that. Again, oftentimes, particularly at Christiana, they'll do just ankle for a heel index. For ABIs, we're just using the ankle cup and break them up to 95 or the front after thigh. And with that, you follow the same steps, you do the pulse volume recording for the brachials, pulse volume recording just for the ankle now. And then you move to your pressure, you just do a pressure for the brachials and pressure for the ankle. You think about that, once you get it all set up, the cuffs, you're rolling. Say it to the morning group, you're available, anyone could come in Mondays or Fridays or whenever you have off from class. practice or Thursdays even. I teach echo on Thursdays, so we're kind of in here in the mornings. But you know, if you're able to come in, practice, you know, just let us know, so that we're here, help you. But, you know.
Are you there Friday?
Fridays from 9 to like 10:30. I have pediatric admin I'm teaching, but pretty much most of the students are coming in via Zoom. That's why I'm here during that time. Setting up the pressures now. So once we've done the pulse volume recording, again, this is measuring volume changes. We're going to go into segmental pressure now with activating the blood pressure. Start with your brachial pressures. This is now a little probe. Gel. On the weight, but as long as you're not like actually touching it, it's like the bottle itself. Oh, yeah. Yeah. Like, for this, it doesn't matter because we're not storing it. So if it's cutting off, it's okay. I usually turn it all the way up to 100. When patients have disease, the waveforms are going to be much smaller and not necessarily help them to see it. Relax your arm, like right, left, yeah, sit flat on the bed. Then back. So maybe about 30 millimeters past that.
No, it was like, it was supposed to be pretty far.
After you finish the first part, that whole spot you're recording, these guys can actually talk, we no longer do that. That partial plus. Thank those. I'm gonna be looking for, well, actually, do this. Forget. Just, yeah, just another one. And we're going to, try and find Versailles venous artery and your tibial artery. Get, those pulses. So you can try and feel, so you can feel, the venous artery. How we're gonna be, so now this is that Versailles venous artery. It's nice because Michigan had teaching for the protocol. So you did both great gills and then the green box winds up down here now. I have to tell you where to go. Yeah, so we're doing Versailles venous artery. So getting the ankle pressure, you have the Versailles venous artery. We're also gonna get the ankle pressure via the posterior tibial artery. So those are both ankle pressures. For the pelvis. So the pressure that's here corresponds to. Find the inner ankle and from just behind the inner ankle. I usually, he had you guys kind of start inward and go outward. I like to start outward and just work my way back inward. Kind of just banging across there until I hear it. And when I hear it, I put a little bit of tilt on it. Or you could even start with the tilt if you want, just get fan outward and put the way that is. That's good. That's good. Look at these two pressures that you got, so without these is 119, posterior tibial is 135. You're gonna use the higher of those two to get, the pressures at the rest of the levels. You're gonna stay on that artery. Okay, so now we're gonna inflate the cap, so you're gonna go back to this artery. You pick whichever one of these is higher, you go back to that artery, and then you're gonna inflate the other segment from that spot. In this case, your posterior tibial is higher, we're gonna utilize that one.
Okay, so now go back and wait all of you.
So you're just gonna find the order here, like this cup, like this cup, like this one. We're gonna get pressure here, here, and then. Okay. Keep it perfect. So this is called the best vessel approach. So in theory, the vessel with the higher pressure is the healthier of the two, or the more dominant of the two, and that's the one you're gonna utilize to get the pressure at the low side. I forgot. Good going. Switch off. Right leg, left leg. More numbers? Yeah. So the main thing we look at is ankle brachial index, so we compare the ankle pressure to your brachial. So normal is between 0.9 and 1.3. So kind of think of it as like a test score, like you get 100 on a test, that's good. A little over 100 is okay.
When you start getting below 0.9, that's when it could potentially be a disease. And the pressures typically go up as you go up the leg, so the thigh pressure goes usually a little bit higher. Than the foot. In terms of thigh, we want 1.2 or greater. So again, I think the machine's gonna kind of take you through the study. Now you're back on, left ankle versus venous. Yep. That's kind of your thing. You just start like you did, and you just start across until you find it. I just realized that too. Like, my ear vision is like gotten really terrible. I think I need to invest in bifocals. I'm like, yeah, this for sure.
I
Like, or you can. I would for Shell in the last class. She was like, she would forget her glasses. There's something like Shell. Find that hearing bolt. So, they're coming that kind of solve the question part, just not find that. So now we look at those two numbers, 134 is our higher, so the south is higher. So we have to go back to the south it is now, do the. Find that one. Yeah. When you guys are in clinical and they ask you what pressure you get, just confident in the answer. I can feel like 134, stick with it. Um, some of the people in the vascular act, like, they'll say like 124, and they'll be like, oh, I got 122. They'll never give you the credit for like actually getting right. You'll always be wrong by 1 or 2. Like, just like, okay. Like, don't get offended or upset or anything like that, you know, they never like the students being right. Incredible, yeah. A couple of them, yeah, they'll be like, where'd you get the pressure the last one? They're like 136. I got 135, 137. It's always do this. Plus, of course, you know, they have purple archer disease or the diabetic started kidney. Then it would be a limited study, and then in your notes, you would just be like, you know, unable to obtain, you know, whatever waveforms for pressure, you know, above the amputation, below the amputation. As you will be comparing all these numbers, looking side to side with the levels and then up and down, looking at the pressure drops. So like, I'm just looking at this kind of outliers. I thought at 132 over here at 96. So I look at those two, and that's a big pressure difference. So the side with the low pressure would potentially indicate disease. So I look at that and see a pressure difference. If I exit out and look at my waveforms, yeah, so I compare my high thigh waveforms, they look pretty similar. They're both healthy. I shouldn't have that pressure difference if this is telling me, you know, that they're both healthy waveforms. Then I mean, all right, I messed up probably. Yeah, so better go back and check yourself. If I just split a little. There's another window that you can get, which I was just kind of coming between these two pillars and an angle like that. Some texts hate for people to go there, particularly students, but you can get a pretty good trace from that kind of doing that. I understand the rationale, they don't rather you try and get it up here because if the patient has purple arterial disease, it's gonna affect some of the smaller arteries more. You're more likely to have the artery included down here than up here. So I understand like the logic of it, but it's pretty easy to kind of get here and build up. Let's stay on the table one time, like. I hope that ends faster. But that's the only flavor you got right now, so. You haven't experienced the other stuff.
No, but just like also like with the lecture. Like you said, yeah, it's still early on.
Actually, it's very numbers driven, so like the numbers are what the numbers are. It's, there's no fudging it, there's no like, oh, it could be this, it could be that, you know, like, it could be this lesion, could be this mass, that type of thing, like, there's no gray areas, right? You're basically just finding blockages in vessels, that's what you're looking for, either blood clots or stenosis. Where is it, how severe is it? Well, what we do, inflate, so moving on. Oh, yeah. put on the period, so like after I cut the black on it, I think. Put your
Like are we going to like our normal lab groups tomorrow? Okay. You guys, I can, announcement, okay. So we don't all have to come, no, yeah, okay, that's fine. Oh, okay. Oh, I thought we talked about that. We did last week, but I'll do a double check. I'll do it again. Okay.
where they can influence, you can come behind and go.
Yes, I know that.
Then I start out lateral, I'm slowly banning the keyboard towards the ball, so I find it. So that one slowly work away.
But now everybody's here and then we'll do the practice. First lap meetings. Second lap seats.
get a little bit more, almost like on the east side. So it's- Now we're looking at these two pressures, so we have 129 and 136. So you have to stay with the artery that has the higher of those two pressures. So in this case, we're good. We're not going to monitor. You're gonna stay there, and I'm just gonna play on that.